anyone tell me that you are listening me properly? Can you hear me properly? Is my voice is clear? Okay. Okay, before starting our new topic, local anesthetic agent, because already we have uh, discussed the general anesthetics, right? My name is Dr. Imran, and uh, I have taken the lecture on inhaled anesthetic agent, but I didn't take the lecture of intravenous anesthetic agent. So when I was taking the lecture of inhaled anesthetic agent, there were two questions that I asked. Number one, what do you mean by diffusion hypoxia? And the second question was, why long-term use of nitrous oxide is responsible to cause megaloblastic anemia? These two questions were the homework after the lecture of inhaled anesthetic agent. So first I tell you what is diffusion hypoxia. So anyone who has done the homework or this task that I gave you, otherwise I will tell you the answer of diffusion hypoxia, which is caused by nitrous oxide, because this is one of the important question or concept that can be asked in the exam. Okay, I am going to tell you about the diffusion hypoxia. You know what we have done? Nitrous oxide, has low blood solubility. This point already we have discussed in the inhaled anesthetic agent. So when the administration of nitrous oxide is discontinued, or we stop the inhalation of nitrous oxide, what will happen? Nitrous oxide rapidly diffuses from the blood into the alveoli and causes marked reduction of partial pressure of oxygen in the alveoli, and that will result to produce hypoxia, which is known as diffusion hypoxia, right? And this problem can be avoided by giving 100% oxygen for a few minutes immediately after nitrous oxide is discontinued. Clear? So this is about the diffusion hypoxia. And the second question was, why megaloblastic anemia can occur if we give the prolonged exposure of nitrous oxide? The reason of this question is prolonged exposure of nitrous oxide decreases methionine synthetase. This is the enzyme methionine synthetase activity, which is inhibited by prolonged exposure of nitrous oxide, and that may lead to megaloblastic anemia. Because methionine synthetase activity is required for the formation of tetrahydrofolic acid, which is required for the DNA synthesis. So if we inhibit the activity of this enzyme, the DNA synthesis is impaired, but RNA synthesis will occur normally, so resulting abnormally large cells. That is called megaloblastic anemia. In short, nitrous oxide decreases methionine synthetase activity and may lead to megaloblastic anemia. There was another question which is important from the exam point of view, and that is also related to inhaled anesthetic agent. Can anyone tell me when malignant hyperthermia can occur? Though it's not a common problem, but in genetically susceptible patient, malignant hyperthermia occur when we use the combination of which anesthetic agents? Malignant hyperthermia is caused by the combination of which anesthetic agent, though it's not a common problem, but in genetically susceptible patient, it may cause, anyone please? Okay, there is answer, halothane and succinyl choline, right? So, can you tell me also the antidote which is available for the treatment of malignant hyperthermia? Okay, there is a reply, dantrolene. Very good, right? So now, local anesthetic agent. My name is Dr. Imran. These are the lecture objectives. At the end of the lecture, you must be able to define local anesthetics, its classification, its mechanism of action, right? And the mechanism of ineffectivity of local anesthetic in certain cases. Understand the role of adrenaline as vasoconstrictive agent, and what are the adverse effects and contraindications of local anesthetic, and pharmacokinetics of local anesthetics. Now, local anesthetics, that is the definition. Local anesthetics are weak basis drugs. This is an important point that you must remember, and it can be applied topically and can be injected locally. Block the nerve conduction, and it causes reversible loss of all sensation in the part supplied by the nerve. So local anesthetics are weak bases. And one important point that you must know, drug is either weak acid or weak base. And in both forms, they must be in uncharged form, unionized form, right? So it can crosses the lipid bilayer and reaches the intracellular side, right? So local anesthetics are weak bases. That means normally these are unionized form, non-charged form, or uncharged form, right? Classification, there are two main classes of local anesthetics, and this you must know, right? This you must know the examples which are included in ester group and the examples which are included in amide group. So we have two major class, esters and amides. In esters, we have a very important example, that is cocaine, procaine, chloroprocaine, benzocaine, and tetracaine. And amide group, we have very important and commonly used local anesthetic agent, that is lignocaine, mepivacaine, bupivacaine, prilocaine, and ropivacaine. So these are the important examples. Okay, in the exam, sometimes if you are unable to recall the actual name, so one important hint that you can easily identify, okay, whether this drug belongs to ester group or amide group. So what is that important point? If you just focus on this slide, suppose first we see the ester group. In all examples, you can see cocaine I, procaine I is there, in chloroprocaine I is there, benzocaine I, tetracaine I, and in amides we have two I, lignocaine double I, mepivacaine double I, bupivacaine double I, prilocaine double I, ropivacaine double I. So this is one of the important hint as far as the BCQs are concerned. So sometimes you have forgotten, okay, whether this drug belongs to ester group or amide group. So this is one of the important hint, right? So in ester group, only one I you will find, but in amide group, we have two I's, right? So this is an important point that you must remember. Now, mechanism of action, which is very important, main side of action of local anesthetic is the cell membrane. Local anesthetics in unionized form, or we can say uncharged form, right, easily penetrate the nerve sheath and the axon membrane. When it will enter into the axon, right? So within the exoplasm, the molecules become ionized, and then it will block the voltage gated sodium channels. So local anesthesia is produced when local anesthetics, they are going to block voltage gated sodium channels. And this blocking activity is take place inside portion of the sodium channel. So first you can say both form of ionized or unionized form is required for the activity of local anesthetics. Unionized form is required for the penetration, so it can reaches the inside the cell. When it will enter inside the cell, it become ionized, and this ionized form block the portion of sodium channels which is located inside and which is responsible for the blockade activity of sodium channels, right? So this is another explanation. So local anesthetics block the voltage gated sodium channels, no entry of ions into the cell, so no depolarization, right? So no generation of action potential, no generation and conduction of impulses to CNS, and local anesthesia is produced. But the important point, what you must remember, local anesthetics are weak bases, number one. Number two, both form of local anesthetic is required. What does it mean? That means in ionized form as well as non-ionized form. Non-ionized form is required for the penetration, right? And ionized form is required for the blocking activity of sodium channels. Now, this is important question. Local anesthetics are less effective in inflamed and infected areas. Why? Is anyone can tell me what could be the reason? Local anesthetics would show the less effectivity in inflamed and infected areas. Okay, there is a reply. Because of decreased blood supply, greater hydrogen content due to inflammation. Okay, because in inflammation and in infection, the environment becomes acidic. And you know, local anesthetics are weak bases. So when there is a change in the pH, what will happen? When when we administer base into acid, what will happen? The base will accept proton, right? Will accept proton, and when it will accept proton, it will get charged, converted into ionized form. So what will happen? Because ionized form is unable to penetrate the cell membrane, so it is difficult to reach inside the cell. Because for reaching inside the cell, local anesthetic must be in unionized form, non-ionized form. When it will enter inside the cell, then it is converted into ionized form, and this ionized form is required to block the sodium channel, right? So this is important point that you must remember. There is another question which is very important. What happens after the addition of a vasoconstrictor to the local anesthetics? You know, the general concept is generally local anesthetics, they are responsible to produce vasodilatation. So what will happen? There is only one exception that I will tell you later on. Generally, all the local anesthetics, they are going to produce vasodilatation. So when there is vasodilatation, you know, increase amount of blood will come in that area, right? Due to vasodilatation. So increase amount of blood will come. So it will washes the uh, local anesthetic agent, right? So its effect will be diminished. So how we can solve this problem? If we add vasoconstricting agent along with local anesthetic, so it will produce vasoconstriction. So the time will increase for local anesthetics to produce its activity, right? Because when vasoconstriction, there is no amount of blood coming, and so washout mechanism we are going to slow down, right? So generally, local anesthetics, they are going to produce vasodilatation except one local anesthetic. So this is one of the questions that is commonly asked in BCQ, and that exception, what is that exception? The only anesthetic agent that is responsible to produce vasoconstriction. Otherwise, generally all the anesthetic agents, they are going to produce vasodilatation except one agent that is responsible to produce vasoconstriction, and the example of that agent is cocaine, right? Example of that agent is cocaine. And the next point that you must know, cocaine belongs to amide group or ester group. Cocaine belongs to amide group or ester group. Okay, there is a reply, ester group. Okay, if you suppose, if you don't know whether it belongs to ester group or amide group, is there anything, any tricky point that you will say confidently, okay, this compound like cocaine belongs to is okay, single I. Okay, you got my point. That is why I was asking this question. Very good. Okay, so what happens after the addition of a vasoconstrictor to the local anesthetic? Now I think this point is clear, that why there is a need to add vasoconstricting agent, right, with local anesthetics. Answer is, it will slow absorption from the local site, which results in prolonged duration of action of local anesthetics, decrease bleeding in the surgical field, right? And slow absorption of local anesthetic reduces its systemic toxicity as well. So these are the reason of adding vasoconstricting agents. But there is, we are not going to always add vasoconstricting agent, because there are some amide group local anesthetic in which there is no marked vasodilatation. So there is no need to add vasoconstricting agent. We can use these local anesthetic agents that belong to amide group, can be used without vasoconstricting agent. What are the disadvantages? Now, this is another important point. If we are adding vasoconstricting agent, and generally, you know which vasoconstricting agent we add with local anesthetic preparation, that belongs to sympathetomimetic drug, and that drug is adrenaline. So what are the disadvantages and contraindications of combining vasoconstricting agent with local anesthetics. Answer is there is a reply first. Okay, there was a response, heart disease, very good. So intense vasospasm and ischemia in tissues, especially with end arteries. End arteries. That means, this is important point. If we have to apply local anesthetic in the organ where end arteries are present, so it is not advisable to give the local anesthetic with vasoconstricting agent. Why? Because intense vasospasm and ischemia in tissues with end arteries may cause gangrene of the part, because there is no collateral available, like fingers, like toes, like penis, like ear lobule, tip of the nose, etc. So in the above sites, use of vasoconstrictor should be contraindicated. Absorption of adrenaline, this point already I told you which vasoconstricting agent generally we add with local anesthetic preparation, that is adrenaline, that is also called epinephrine, and this is one of the important neurotransmitter related to sympathetomimetic drugs, right? So absorption of adrenaline can cause systemic toxicity like tachycardia, palpitation, raise of blood pressure, and precipitation of angina or cardiac arrhythmias. Because if we just recall, adrenaline acts on adrenergic receptors. And what are the different adrenergic receptors? We have alpha-1 receptors, we have alpha-2 receptors, we have beta-1 receptors, we have beta-2 receptors. So this systemic toxicity like tachycardia, palpitation, rise of blood pressure, and precipitation of angina or cardiac arrhythmias involve which receptors? Especially alpha-1 receptors and beta-1 receptors, because alpha-1 receptor is stimulation responsible to cause vasoconstriction that will lead to increased venous return, right? So that will lead to increased cardiac output and it will cause the increased blood pressure. And due to stimulation of beta-1 receptor, increase cardiac contractility, increase conduction, right? So these are the problems that can occur due to the absorption of adrenaline if we add with local anesthetic agents. May delay wound healing by reducing the blood flow to the affected area, right? So this is another drawback of adding vasoconstricting agents. Now the pharmacokinetics, this is also important, and already we have discussed that we have two types of group related to local anesthetics. One is ester group and the another one is the amide group. Most of the ester linked local anesthetics are rapidly metabolized by plasma cholinesterase, that is also called pseudocholinesterase, right? So ester related or ester linked local anesthetics, they are metabolized by plasma cholinesterase, whereas amide linked drugs are metabolized mainly in the liver. So there is a clinical correlation. Clinically, which group is being used extensively or commonly? This is another important question. Which group, ester group or amide group? Which one we clinically prefer or we are using extensively? Which group? Amide group. Very good, right? So that means if a patient, because amide linked drugs are metabolized mainly in the liver. So if a patient having a liver disease, liver problem, So we'll have to be very, very careful, because due to liver disease, amide local anesthetics, they are not going to metabolize properly. So the level of amide local anesthetic may increase in the blood and it may produce toxicity. Local anesthetic like procaine, lignocaine are not effective orally because of high first pass effect. Procaine belongs to ester group and lignocaine belongs to amide group, right? So these are the two examples that cannot be given orally. Why? Because of high first pass effect. What does it mean? That means most of the drugs, if we give these drugs orally, so most of the drugs, like 80 to 90% drugs, are metabolized. So the available less amount of drug available to produce any activity. So this is the reason that we cannot give procaine and lignocaine orally. In liver disease, the metabolism of lignocaine may be impaired, so dose must be reduced accordingly. So this point already we have discussed, because this is the general concept, and especially if we are using amide group, so we must rule out the liver disease. Adverse effects, CNS related adverse effects. Local anesthetic initially causes CNS stimulation and followed by depression. The stimulatory symptoms are restlessness, tremor, headache, drowsiness, confusion, and convulsions, that is followed by respiratory depression, coma, and death. So this convulsion or respiratory depression, coma, and death, these problems will occur if we use the high doses, toxic doses, or the concentration of local anesthetic reaches up to the toxic level. CVS related adverse effect, it may cause bradycardia, hypertension, cardiac arrhythmias, and rarely cardiovascular collapse and death. Rarely, right? Again, if we are not going to calculate the dose properly, or very high doses accidentally, or multiple doses of local anesthetics are given, then there is a chance of cardiovascular collapse and death. But normally it doesn't occur. Now, this is the important point from the BCQ point of view. This bupropion is highly cardiotoxic. So this is one of the questions that can be asked in the BCQ. And you know, I have given the hint because this drug having two eyes, so definitely this drug, this local anesthetics belongs to amide group, and this bupropion is highly cardiotoxic. So this we must remember as far as the PCQ question is concerned. Now the third one is the allergic reactions. These are skin rashes, itching, erythema, urticaria, wheezing, bronchospasm, and rarely anaphylactic reaction. The incidence, this point is important. The incidence of allergic reactions is more with ester-linked local anesthetics than with amide-linked local anesthetics, right? So this is another reason of using amide group commonly as compared to ester group, right? So because why we are not using ester group commonly, because the incidence of allergic reactions more with ester-linked local anesthetics. Mucosal irritation, especially with cocaine, because you know this is the only local anesthetic agent which causes vasoconstriction, right? Otherwise, all the local anesthetics, more or less, they are responsible to cause vasodilatation. Some local anesthetics, they are producing marked vasodilatation, some are moderate, and some mild form of vasodilatation, but vasodilatation is there, except in case of cocaine, which is responsible to produce vasoconstriction. So this vasoconstriction may lead to mucosal irritation. And methemoglobinemia, this is another peculiar side effect of a local anesthetic agent. Name is prilocaine. And this prilocaine belongs to amide group. So one of the important peculiar point related to amide group is the bupivacaine, which is highly cardiotoxic, and which local anesthetic agent may cause methemoglobinemia, and your answer would be prilocaine. So these you must remember. Now one by one, now the first we discuss the amide group, the only class of anesthetics used parenterally, right? Parenterally. Esters are occasionally used topically. The relative lack of allergenicity of the amide is probably for this one already we have discussed. Now amide group number one, lidocaine. The other name that we can memorize, lignocaine, right? The same thing, lidocaine or lignocaine. And this is the local anesthetic agent which is most commonly used, right? And it's of medium duration of action. Adverse reactions include hypertension, positional headache, shivering, right? And I think if you have joined the ward and if you have attended the ward, you know, lidocaine, this is the preparation. This lidocaine not only available as a topical form, right, as well as in the injectable form, right? Like if we catheterize our patient, right? So we use gel of lignocaine, which is the name which is available, that is the xylocaine gel, right? So if we pass the NG tube, we use xylocaine gel. So all these application is the topical application, but it can also be used as the injectable form, right? So this point is important. Second one is the mepivacaine. Its rate of onset, duration, potency, and toxicity are similar to those of lidocaine. But this mepivacaine is not effective topically, right? So the point already I told you, topically, like what are the conditions in which we use lignocaine topically? So what are the examples that you have observed? Anyone in the ward or in the hospital setup? So what are the conditions where the xylocaine gel or lidocaine or lignocaine is being used topically? Okay, there is a reply. In burn cases, okay. And two examples I have mentioned. Okay, there is another reply, okay, for the catheterization and for passing NG tubes, right? And the xylocaine gel is also used in case of hemorrhoids. In case of hemorrhoids, right? Okay, so mepivacaine, just like lidocaine, but what is the important point of this mepivacaine? It is not effective topically. However, it's used for infiltration, nerve block, spinal anesthesia, epidural anesthesia, and caudal anesthesia. Because mepivacaine produces less vasodilatation than lidocaine, right? So this point, this also we have already discussed in the beginning of the lecture. Generally, local anesthetics, they are going to cause vasodilatation, but this vasodilatation may be varied. So some are responsible to produce marked vasodilatation. So any anesthetic agent which is responsible to produce marked vasodilatation, so we can add agent, but there are some local anesthetics, they are not going to produce marked vasodilatation. So in that situation, it can be used without vasoconstricting agent. So here, in this case of mepivacaine, because mepivacaine produces less vasodilatation than lidocaine, so can be used for short procedures when a vasoconstrictor is contraindicated. And already we have discussed some important contraindications of local anesthetic. So what is the difference between lidocaine and mepivacaine? Both are amide group. Rate of onset, duration, potency, and toxicity are similar, but two important differences. Number one, mepivacaine cannot be used effectively when we applied it topically. And number two important point, that is the beneficial point, because it's not going to produce marked vasodilatation, so it can be used without vasoconstricting agent, especially if there are some contraindications of adding vasoconstricting agent with local anesthetic. So this is one of the example of mepivacaine that can be used without vasoconstricting agent. Now this very important example, prilocaine, and one important point already we have discussed in the slide, in the previous slides, one of the previous slide. So what is that important point of this amide group that you must remember? So it may cause which problem? Prilocaine. Okay, there is a reply. Methemoglobinemia, very good. Now, prilocaine is related chemically and pharmacologically to both lidocaine and mepivacaine. Chemically, lidocaine and mepivacaine are xylidine derivatives, whereas prilocaine is toluidine derivative, right? So prilocaine appears to be less potent and less toxic. Less potent, less toxic than lidocaine, and has a slightly longer duration of action, right? So if we are not required the potent local anesthetic agent, we can use this drug, because less potent, this is a general concept, less potent drug definitely will cause less toxicity, right? And this prilocaine has longer duration of action. The important point of this prilocaine is metabolized to orthotoluidine, right? Orthotoluidine, and in large doses can induce some methemoglobinemia. So methemoglobinemia, which is caused by prilocaine, basically is caused by the metabolite of prilocaine. And what is the name of that metabolite? That is orthotoluidine. Clear? Drugs that affect the hemoglobin, such as acetaminophen, may exacerbate the adverse reaction. Prilocaine is used for infiltration, nerve block, epidural, and for anesthesia. It cannot be used topically. Bupivacaine, this is another very important drug that belongs to amide group, and this bupivacaine is related to lidocaine and mepivacaine. More potent. This is very peculiar, important point. Usually, the mepivacaine and lidocaine, they are potent, as well as chances of toxicity. And this bupivacaine, this is more potent than lidocaine and mepivacaine, at the same time less toxic. So this is very important point of this bupivacaine. The major advantage is its greatly prolonged duration of action. So if and you know why it's necessary to know about the duration of action of different local anesthetics, because we are going to select the drug according to the duration, probable duration, which is required for any procedure. So we must know, okay, this procedure at least will take this time, so this agent would be appropriate, right? So this is the major advantage of bupivacaine, is greatly prolonged duration of action, and at the same time is less toxic if we compare with lidocaine and mepivacaine. Now the esters group, there is another examples as well in amide group, but I have discussed the key examples of amide group. If anyone is interested, he or she can go through the book, right? But at least you must remember these important amide local anesthetic agents. Now the esters, procaine, and procaine is a power para-aminobenzoic acid ester, and procaine is used, this is important point, procaine is used as an antiarrhythmic agent and is combined with, this is another use of procaine, it can be combined with penicillin to form procaine penicillin G. The allergic reaction is usually a result of para-aminobenzoic acid and not because of procaine, right? Tetracaine, an ester of again para-aminobenzoic acid, has a slow onset and long duration and is generally estimated to have at least the potency and toxicity of procaine. That means it's a powerful local anesthetic of ester group, but at the same time increased chances of toxicity as well. Tetracaine is available in various sprays, solutions, and ointment for topical application. So this tetracaine is another example of local anesthetic that can be used topically after lidocaine. Other local anesthetics, benzonatate is a tetracaine cogner indicated in the management of non-productive cough, or we can say the dry cough, right? A topical anesthetic that acts on the respiratory stretch receptors, which produces its antitussive properties, right? Benzonatate. This is all about the local anesthetics. That is from the your exam point of view, right? So I think I have summarized this local anesthetics and I have repeated important points related to this topic, right? So everyone got the answer that I asked. I'm repeating again that when I delivered the lecture on inhaled anesthetic agent, but I didn't deliver the lecture on intravenous anesthetic agent. So when I delivered the lecture on inhaled anesthetic agent, I asked, I gave you the homework of 2 questions. What do you mean by diffusion hypoxia? So for those students who joined us lately, so I'm repeating again. So about the diffusion hypoxia, because my question was, so nitrous oxide is responsible to cause diffusion hypoxia. Why? So I'm repeating again the answer, because you know nitrous oxide has the low blood solubility. So when the administration of nitrous oxide is discontinued or stopped, so now what will happen? You know, the reverse phenomena of diffusion. Now maximum concentration in the brain. So the molecule will move from brain, so back to the lungs. So nitrous oxide rapidly diffuses from the blood into the alveoli and causes marked reduction of oxygen arterial pressure, oxygen pressure, partial pressure in the alveoli, resulting hypoxia, which is known as diffusion hypoxia, because this is because of the rapid diffusion, back diffusion from the brain and back into the alveoli, and then it can be exhaled out. But it can be avoided by giving 100% of oxygen for a few minutes immediately after nitrous oxide is discontinued. My second question was why prolonged exposure of nitrous oxide may cause megaloblastic anemia. And the answer is prolonged exposure of nitrous oxide decreases methionine synthetase activity, and that may lead to megaloblastic anemia. If you just recall the biochemistry, right? Because you know methionine is synthetase is responsible for the formation of tetrahydrofolic acid, which is required for the DNA synthesis. So if we inhibit the activity of methionine synthetase, so what will happen? That non-availability of tetrahydrofolic acid, which is required for the DNA synthesis, but the RNA synthesis is continued, so that will lead to enlarged form of RBCs, that is called the megaloblastic anemia. The third point that is very important, again, that is related to inhaled anesthetic agent, and the question is asked in the exam, malignant hyperthermia. So malignant hyperthermia is not a common problem, but in genetically susceptible patient. So for few minutes, the question is, sir, we give oxygen for how long in diffusion hypoxia? That already I told you, it can be avoided by giving 100% oxygen for a few minutes. For a few minutes, immediately after nitrous oxide is discontinued, right? Because you know it rapidly diffuses back into the alveoli. So few minutes would be sufficient to avoid the diffusion hypoxia, right? So malignant hyperthermia is produced when we give the combination of inhaled anesthetic like halothane along with one of the neuromuscular blocking agent. Because if you just recall the lecture, this is one of the important characteristic feature, you know, three important triad of anesthesia. That is the amnesia or anesthesia or unconsciousness, analgesia, and skeletal muscle relaxant. So for skeletal muscle relaxant, we use succinylcholine. So when we use the combination of halothane and succinylcholine, so in some patients who are genetically susceptible may cause malignant hyperthermia, right? And which antidote we can give to treat the malignant hyperthermia? And one of the students already gave me the reply, that is dantrolene, right? So these are the points that you must remember. I think this is all about. So thank you so much. So in the upcoming lectures, let's see who is going to take the lectures. So inshallah, we will meet again in one of the lecture of this CNS, right? So thank you so much. Allah Hafiz.